Great, thanks, Sushil. So I'm going to start out with a predictable lecture, and then hopefully throw you a curveball in the middle. Okay. So start with some simple facts about TR. We actually avoided those so far. TR often develops secondary to pulmonary hypertension with or without overt RV dysfunction, from atrial myopathy secondary to long-standing AFib, or can be iatrogenic from device leads or endomyocardial biopsies. Moderate or greater TR is an independent predictor of increased heart failure hospitalization and mortality. Remember, predictors and associations aren't causality. Tricuspid valve surgery, as you've heard, is rarely performed for isolated TR given substantial morbidity and mortality and uncertain efficacy. And the safety and effectiveness of transcatheter approaches for aortic and mitral valve diseases have spurred the development of similar approaches to reduce TR. So when you look at some of the data leading into the randomized trials, we were really optimistic. And this is from the TriValve Registry of Tricuspid Valve Interventions, looking at a non-randomized but propensity-matched analysis. You've seen a lot of propensity-matched analyses this morning, people saying those are the best data we have before randomized trials. Well, here was the best we had going into the randomized tricuspid trials, 472 patients who had greater than or equal to moderate TR, who either got a tricuspid valve intervention, mostly TTR, versus just medical therapy. And when you did adjusted analyses for all the potential covariates and echocardiographic parameters, there were 60% reductions in heart failure hospitalization and in mortality, 60%. So we went into these randomized trials really optimistic to see kind of what we saw in COAPT, reduced death and heart failure hospitalization. So now we have two major randomized trials to look at. The Triluminate, an open-label randomized trial of the TriClip versus medical therapy, and TriScend II, open-label randomized trial of Evoke versus medical therapy. And if you look at the baseline features, it's hard to always, it's always fraught to compare one trial to another, but they look relatively similar, somewhat more women in TriScend II. The history of heart failure a little bit worse in TriScend II, but at least by core lab analysis, there was more torrential tricuspid regurgitation in the Triluminate trial. If you look at the effectiveness of these devices in reducing TR, they both reduced TR, but Evoke was more effective. If you look at the a reduction to mild or less TR, it was 95% at 1 year with Evoke versus 50% with TriClip. So both effective in reducing TR, but especially Evoke. Now what about, let's get to clinical outcomes. How about quality of life? Well, if we look at KCCQ, which is our best heart failure correlate of quality of life, marked improvements in quality of life in these two open-label trials. So the difference, the between-group difference in the improvements in quality of life were 13.5 points in the Triluminate trial and 17.8 points in the TriScend II trial. 5 points is the minimal clinically important difference. Those are big differences. That's very similar to what we saw in COAPT. There were also improvements in NYHA class and also some improvements in 6-minute walk distance as well. But there was no difference whatsoever in death, cardiovascular death, or heart failure hospitalization in either of these two trials. Now you might say, well, maybe 1 year is too early to see a difference in mortality. In fact, in COAPT, it took beyond 1 year to see the mortality difference, but we immediately saw a reduction in heart failure hospitalizations. And here you don't really see that. Very, very weak trends, but nothing approaching significance. So huge benefit in terms of patients feeling better, but then that doesn't translate into them not needing to be hospitalized for heart failure. And what about complications? Well, TTR was quite safe. We don't really see an increase in any sort of complication, including pacemakers, repeat surgeries, et cetera. Major bleeding was only about 3% of the cases. Evoke was a less safe procedure. There was a high incidence of major bleeding and particularly an increased incidence of the need for permanent pacemakers. So, there are trade-offs between these two. So let's summarize, okay? Both TriClip and Evoke reduced TR. Evoke was more effective. Both TriClip and Evoke markedly improved KCCQ and NYHA class without reducing death or heart failure hospitalization. Complications were more frequent with Evoke than TriClip, especially major bleeding and permanent pacemakers. So then the question of my talk, I was asked to discuss, are randomized trials between transcatheter tricuspid valve repair versus replacement necessary? Well, yes. What did you think I was going to say? Okay? Because the issue is, for tricuspid valve anatomies that are amenable to either approach, and that's not all cases. Some are only going to be amenable to tricuspid valve replacement. But for the ones that you think you can approach reasonably with T-TIR, does the greater TR reduction with tricuspid valve replacement translate into greater improvements in quality of life and functional capacity, or possibly better reductions in death or heart failure hospitalization, warranting its increased risks? So far, we don't see that. And so far, T-TIR is clearly the safer procedure, so far T-TIR is the preferred approach, in my opinion, for cases that can be approached by T-TIR. But, you know, again, riskier procedures need randomized data to show greater efficacy. But now for the curveball, okay? There's an issue of even greater importance that's hot off the press. The only benefits of both of the clinical devices in these open-label randomized trials were improvements in the relatively soft outcomes, KCCQ, NYHA, 6-minute walk, that are prone to substantial placebo and Hawthorne effects and ascertainment and other biases in unblinded studies. Blinded studies have recently suggested that changes in KCCQ, NYHA, and 6-minute walk do not correlate with death and heart failure, as we used to think they do, and may not be approved by effective heart failure therapies if you blind patients to whether or not they got a new therapy. So we've really got to ask ourselves, if we're honest and we want to provide safe and effective therapy for our patients, how much benefit do these devices truly provide? So KCCQ has been validated over and over again, and I love it. I've used it in a lot of my trials as a validated instrument to assess heart failure-related symptoms. I've looked at every single question it asks, and you can say, how can these not be related to heart failure systems? And it's been validated against death and heart failure hospitalization, but mostly in open-label trials. So for example, in COAPT, as you mentioned, there's this huge early benefit in a reduction of heart failure hospitalizations with MitraClip compared to medical therapy alone, and later reductions in mortality. And if you look, there's a very early big benefit in improvement in KCCQ, about a 16-point difference compared to what you see with medical therapy alone. Again, minimal clinically important difference is 5 points. So about 16-point difference, and the improvement in KCCQ is associated with about 20% reductions in death and heart failure hospitalization, and a 25% reduction in death or heart failure hospitalization. Validating KCCQ, right? But then we've got these two trials. Marked benefits in KCCQ, but no difference whatsoever in death and heart failure hospitalization. And again, the KCCQ difference is similar to what we saw in COAPT. So these are open label trials. So is this all the placebo effect? I was really happy in COAPT. I was a little nervous if we weren't going to see any death or heart failure hospitalization. But when we got that, then I was really happy, and I said, okay, well, obviously the KCCQ follows. But what about in these trials? Is this all placebo effect, or is a lot of placebo effect? Or is our transcatheter tricuspid valve interventions the one unusual therapy that only improves symptoms and don't reduce death or heart failure hospitalization? And how do you get a marked improvement in heart failure symptoms, but no difference in whether or not patients end up having to be hospitalized for heart failure? So now I digress for 1 minute, and this is new data that really kind of, I think, has opened my eyes, and this is what you're going to be hearing about for the next 5 years a lot. So we did a trial called RELIEVE-HF. And this was 508 patients, which was a blinded sham or placebo procedure-controlled trial of heart failure patients who got an interatrial shunt versus a sham procedure. And these were patients with any ejection fraction, 508 patients, recently reported and published. And when we looked at clinical cardiovascular events, we saw marked differences in patients with reduced ejection fraction and preserved ejection fraction. Patients with a reduced ejection fraction had a marked reduction in events with the shunt. Okay, 50% reduction. At the end of 2 years, the curves are still spreading. P-value is 8 zeros and a 1. Patients with a preserved ejection fraction had increased cardiovascular events. So reduced ejection fraction, doubling of heart failure, 50% reduction in heart failure hospitalizations. Preserved ejection fraction, doubling of heart failure hospitalizations, and increased mortality. So how does these hard clinical outcomes compare with KCCQ in this blinded trial? And here it is. There's about a 10 percentage point placebo effect. All the patients in this trial said by very frequent assessments of KCCQ in a blinded trial that they were feeling better, okay? But there was no difference between groups. So if you look at the HFrEF group on the left, these patients had a 50% reduction in heart failure hospitalizations with a shunt, but that didn't make them feel relatively better than the control group. And even more strikingly, if you look at the patients with preserved ejection fraction, the shunt doubled their heart failure hospitalization rates and tripled their mortality. But they thought they were feeling better. Everyone thought they were feeling better in a blinded trial. This really makes you question a lot of the utility of KCCQ. Well, maybe this was an outlier. Maybe we did something weird. So we started to go back and look at other blinded trials that reported the outcomes of hard clinical cardiovascular outcomes and KCCQ. And here's a lot of the recent ones. They're mostly pharmacology trials because there have been very few blinded device trials. So here's recent big trials in HFrEF and HFrEF that showed marked reductions in cardiovascular death and heart failure hospitalization, 20 to 25%, and almost no change in KCCQ, well below the minimal clinically important difference. And now you compare that to RELIEVE-HF, where you see with a device even bigger reductions in clinical events in HFrEF, increases in clinical events related to heart failure in HFpEF, and minimal changes in KCCQ. Blinded trials, we don't see changes in KCCQ. We're doing a huge systematic analysis going back 10 years now, and other people are doing this too because this has become a real issue. So bottom line, are randomized trials between transcatheter tricuspid valve repair and replacement necessary? Yes, absolutely. And it's essential that all such randomized trials be as blinded as possible. Indeed, future randomized trials of tricuspid valve therapy should be sham-controlled to remove all doubt as to the magnitude of their beneficial effects. Thanks very much.